Hello everybody, I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and today we will talk about cardiovascular examination. Complete examination of all systems is essential to detect peripheral and systemic effects of cardiac disorders and evidence of non-cardiac disorders that might affect the heart, or vice versa. Examination includes the following: vital sign measurement, palpation and auscultation, vein observation, chest inspection and palpation, cardiac percussion, palpation and auscultation, a lung examination including percussion, palpation and auscultation, extremity and abdomen examination. Cardiac auscultation will be discussed in a separate lecture. Despite the ever-increasing use of cardiac imaging, bedside auscultation remains useful as it is always available and can be repeated as often as desired without cost. Vital signs include blood pressure, heart rate rhythm, respiratory rate, and temperature. Blood pressure is measured in both arms and for suspected congenital cardiac disorders or peripheral vascular disorders in both legs. The bladder of an appropriately sized cuff encircles 80% of the lump's circumference, and bladder's width is 40% of the circumference. The first sound heart is as the mercury column falls is systolic pressure. Disappearance of the sound is diastolic pressure, so-called fifth phase Korotkov sound. Up to a 15 millimeter hydrargyrum pressure differential between right and left arms is absolutely normal. A greater differential suggests a vascular abnormality, for example, dissecting thoracic aorta dissection, or a peripheral vascular disorder. Leg pressure is usually 20 millimeter hydrargyrum higher than arm pressure. To obtain an accurate blood pressure measurement, the patient should be seated in a chair like me, not on the examination table, for more than 5 minutes, feet on floor, back supported. Have the limb supported at heart level with no clothing covering the area and cuff placement. Abstain from exercising, consuming caffeine or smoking for at least 30 minutes before the measurement is taken. Heart rate and rhythm are assessed by palpating the carotid or radial pulse, or by cardiac auscultation if arrhythmia is suspected. Some heartbeats during arrhythmias may be audible but do not generate a palpable pulse. Respiratory rate, if abnormal, may indicate cardiac decompensation or a pulmonary lung disorder. The rate increases in patients with heart failure or anxiety and decreases or becomes intermittent in the moribund. Shallow rapid respiratory may indicate pleuritic pain. Temperature may be elevated by acute rheumatic fever or cardiac infection, for example endocarditis. God save, endocarditis. After a myocardial infarction, low-grade fever is very common. Other causes are sought only if fever persists more than 72 hours. Ankle brachial index. Ankle brachial index. The ankle brachial index, AB, is the ratio of systolic blood pressure in the ankle to that in the arm. With the patient recumbent, the ankle blood pressure is measured in both dorsalis pedis and posterior tibial arteria, and the arm blood pressure is measured in both arms at the brachial artery. The index is calculated for each lower extremity by dividing the higher of the dorsalis pedis or posterior tibial pressure in that extremity by the higher of the two brachial artery systolic pressure. This ratio is normally more than 1. A Doppler probe may be used to measure blood pressure at the ankle if the pedal pulses are not easily palpable. A low, less than 0.90 ankle brachial index suggests peripheral arterial disease, which can be classified as mild, index 0.71 to 0.90, moderate, 0.41 to 0.70, or severe, less than 0.40. A high index, more than 1.30, may indicate non-compressible leg vessels, as may occur in conditions that are associated with the blood vessel classification, for example, diabetes mellitus, end-stage renal disease, Monkenberg arteriosclerosis. A high index may suggest that further vascular studies are needed. Toe brachial index or arterial duplex studies. Orthostatic changes, blood pressure and heart rate are measured with the patient's supine, seated and standing. A 1-minute interval is needed between each change in position. A difference in blood pressure of less than 10 millimeter hydrargyrum and a change in heart rate of less than 20 beats per minute is normal. In orthostatic, this is orthostatic changes. The difference in blood pressure tends to be a little greater in the elderly due to loss of vascular elasticity. Pulses paradoxes. Normally during inspiration, systolic arterial blood pressure can decrease as much as 10 millimeters hydrargyrum and pulse rate increases to compensate. An exaggeration of this normal response with a greater decrease in systolic blood pressure or weakening of the pulse during inspiration is considered pulsus paradoxis. Pulsus paradoxis occurs in cardiac tamponade very, very commonly, constructive pericarditis, severe asthma, and occasionally in chronic obstructive pulmonary disease, restrictive cardiomyopathy, severe pulmonary embolism, and hypovolemic shock, rarely. Blood pressure decreases during inspiration because negative intrathoracic pressure increases venous return and hence right ventricle filling. As a result, the interventricular septum bulges slightly into the left ventricle outflow tract, decreasing cardiac output and thus blood pressure. These mechanisms and the drop in systolic blood pressure is exaggerated in disorders that cause high negative intrathoracic pressure, for example, asthma, or that restrictive right ventricle filling, for example, cardiac tamponade, cardiomyopathy, or outflow, for example, pulmonary embolism. Pulsus paradoxis is quantified by inflating a blood pressure cutoff just above systolic blood pressure and deflating it very slowly, for example, less than 2 millimeter hydrargyrum per heartbeat. The pressure is noted when Korotkov sounds are at first heard, at first only during expiration, and when Korotkov sounds are heard continuously. The difference between the pressure is the amount of pulsus paradoxis. Peripheral pulses. Major peripheral pulses in the arms and legs are palpated for symmetry and volume, intensity. Elasticity of the arterial wall is noted. Absence of pulses may suggest an arterial disorder, for example, atherosclerosis or systemic embolism. Peripheral pulses may be difficult to feel in obese or muscular people, athletes. The pulse has a rapid upstroke, then collapses in disorders with a rapid runoff of arterial blood. For example, anteriovenous communication, aortic regurgitation. The pulse is rapid and bounding in hyperthyroidism and hypermetabolic states. It's slow and sluggish in hypothyroidism. If pulses are asymmetric, auscultation over peripheral vessels may detect a bruit due to stenosis. Observation, palpation, and auscultation of both carotid pulses may suggest a specific disorder. So I will put all them in presentation. I will prepare a presentation for you. So it will be called visual guide to cardiovascular examination. Okay, visual guide to cardiovascular examination. Okay, I will prepare it. So don't forget to follow that, huh? Visual guide to cardiovascular examination. I will prepare. So aging and atherosclerosis lead to vessel rigidity, which tends to eliminate the characteristic findings. In very young children, the carotid pulse may be normal, even when severe aortic stenosis is present. Auscultation over the carotid arteries can distinguish murmurs from bruits. Murmurs originate in the heart or great vessels and are usually louder over the upper precordium and diminish toward the neck. Bruits are higher pitched and heard only over the arteries and seem more superficial. More superficial. An arterial bruit must be distinguished from a venous hum. Unlike arterial bruit, a venous hum is usually continuous, heard best with the patients sitting or standing, and is eliminated by compression of the ipsilateral internal jugular vein. Peripheral veins. The peripheral veins are observed for varicosities, arteriovenous malformations, and shunts, and overlying inflammation and tenderness due to thrombophlebitis. An arteriovenous malformations or a shunt produces a continuous murmur heard on auscultation, and often palpable because resistance is always lower in the vein than in artery during systole and diastole. The neck veins are examined to estimate venous wave height and waveform. Height is proportional to right atrial pressure, and waveform reflects events in cardiac cycle. Both are best observed in the internal jugular vein. The jugular vein, jugular vein, are usually examined with the patients reclining at 45%. The top of the venous column is normally just above the clavicles, upper limit of normal, 40 centimeter above the sternal notch in a vertical plane. The venous column is elevated in heart failure, volume overload, cardiac tamponade, constructive pericarditis, tricuspid stenosis, superior vena cava obstruction, or reduced compliance of the right ventricle. In such conditions are severe, the venous column can extend to jaw level, and its stop can be detected only when the patient sits upright or stands. The venous column is low in hypovolemia. Normally, the venous column can be briefly elevated by firm hand pressure on the abdomen, hepatojugular or abdominojugular reflex. The column falls back in a few seconds, maximum 3 respiratory cycles or 15 seconds. Despite continued abdominal pressure because of compliant right ventricle increases its stroke volume via the Frank-Starling mechanism. However, the column remains elevated more than 3 centimeters centimeters during abdominal pressure in disorders that cause a dilated and poorly compliant right ventricle or in obstruction of right ventricle filling by tricuspid stenosis or right atrial tumor. Normally, the venous column falls slightly during inspiration as lowered intrathoracic pressure draws blood from the periphery into vena cava. A rise in the venous column during inspiration, Kussmaul sign of Kussmaul, occurs typically in chronic constructive pericarditis, right ventricle myocardial infarction, and chronic obstructive pulmonary disease, COPD, and usually in heart failure and tricuspid stenosis. Jugular vein waves, they also put them in normal jugular vein waves. I'll put in PowerPoint presentation. In presentation, visual guide to this lecture to cardiovascular examination. So jugular vein waves can usually be discerned clinically, but are better seen on the screen during central venous monitoring. The A waves are increased in pulmonary hypertension and tricuspid stenosis. Giant A waves, or cannon waves, occur in atrioventricular dissociation within the atrium contracts while the tracheus valve is closed. The A waves disappear in atrial fibrillation and are accentuated when right ventricle compliance is poor, for example, in pulmonary hypertension or pulmonic stenosis. The V waves are very prominent in tricuspid regurgitation. The X descent is step in cardiac tamponade when right ventricle compliance is poor. The V descent is very abrupt because the elevated column of venous blood rushes into the right ventricle when the tricuspid wave opens, only to be stopped abruptly by the right ventricle wall in restrictive myopathy. On the pericardium in constrictive pericarditis. Chest contour and any visible cardiac impulses are inspected. The pericardium is palpated for pulsations, determining apical impulse and thus cardiac sinus, and thrills. Chest deformities may occur a number of disorders. Shield chest and pectus carinatum, a prominent bright-like sternum, may be associated with Marfan syndrome, which may be accompanied by aortic root or mitral valve disease, or Noonan syndrome, which may be accompanied by pulmonic stenosis, atrial septal defects, or hypertrophic cardiomyopathy. Rarely, a localized upper chest bulge indicates aortic aneurysm due to Lewis, syphilis. Pectus excavatum or depressed sternum. Pectus excavatum with a narrow anteroposterior chest diameter and an abnormally straight thoracic spine may be associated with hereditary disorders involving congenital cardiac defects. For example, Turner syndrome, Noonan syndrome, and sometimes Marfan syndrome. Approaching the patient from the right side, this we called about palpation. Systematically palpate the precordium with the patient laying on approximately a 30 to 45 degree angle. The apical impulse in healthy individuals should be palpable between 4 and 5 intercostal space, just medial to mid-clavicular line, and cover an area less than 2 to 3 cm in diameter. A central precordial have is a palpable lifting sensation under the sternum and anterior chest wall to the left of the sternum. It suggests severe right ventricular hypertrophy. Occasionally, in congenital disorders that cause severe right ventricular hypertrophy, the precordium visibly bulges asymmetrically to the left of the sternum. Sustained thrust at the apex, easily differentiated from the less focal, somewhat diffuse precordial have of right ventricular hypertrophy, suggests left ventricular hypertrophy. Abnormal focal systolic impulses in the pericardium can sometimes be felt in patients with dyskinetic ventricular aneurysm. An abnormal diffuse systolic impulse lifts the precordium in patients with severe mitral regurgitation. The lift occurs because the left atrium expands, causing anterior cardiac displacement. A diffuse and inferolaterally displaced apical impulse is found when the left ventricle is dilated and hypertrophied, for example, in mitral regurgitation. Thrills are a palpable buzzing sensation present with particularly loud murmurs. Their location suggests the cause. I will show them the cause, so location of thrills and associated disorders in presentation. Okay, in visual guide to cardiovascular examination. So don't forget to follow. A sharp impulse at the second intercostal space to the left of the sternum may result from exaggerated pulmonic pulmonic valve closure in pulmonary hypertension. A similar early systolic impulse at the cardiac apex may represent closure of a stenotic mitral valve. Opening of the stenotic valve sometimes can be felt at the beginning of a diastole. These findings coincide with an augmented first heart sound and an opening snap of mitral stenosis. Hard on auscultation. The lungs are examined for signs of pleural effusion, pulmonary edema, which may occur with cardiac diseases such as heart failure. The lung examination includes percussion, palpation, and auscultation. Percussion is the primary physical maneuver used to detect the presence and level of pleural effusion. Finding areas of dullness during percussions signifies underlying fluid or less commonly consolidation. Palpation includes tactile fremitus, vibration of the chest wall felt while a patient is speaking. Ararat, for example. Fremitus is decreased in pleural effusion and pneumothorax and decreased in pulmonary consolidation. For example, lobar pneumonias. Auscultation of the lungs is an important component of the examination of patients with suspected cardiac disease. The character and volume of breath sounds are useful in differentiating cardiac from pulmonary disorders. English is not my that's not very good. Adventitious sounds are abnormal sounds such as crackles, ronchi, wheezes, and stridor. Crackles, previously called rails, and wheezes are abnormal lung sounds that may occur in heart failure as well as non-cardiac disease. So crackles, rails, are discontinuous, adventitious breath sounds. Fine crackles and short, high-pitched sounds, coarse crackles, are longer-lasting, low-pitched sounds. Crackles have been compared to the sound of crinkling plastic wrap and can be simulated by rubbing strands of hair together between two fingers near one's ear. They occur most commonly with atelectasis, alveolar filling processes, for example, pulmonary edema in heart failure, and interstitial lung disease, for example, pulmonary fibrosis. They signify opening of collapsed airways or alveoli. Wheezes are whistling, musical breath sounds that are worse during expiration than inspiration. Wheezing can be a physical finding or a symptom and is usually associated with dyspnea. Wheezes occur most commonly with asthma, but can also occur in cardiac disease such as heart failure. I'll try to put these sounds in here, okay? For example. So, wheezing. Wheezing. Now this was wheezing. Okay, once again for wheezing, please. So this was wheezing. So thanks. Abdominal and extremity examination. Abdomen and extremities are examined for signs of fluid overload, which may occur with heart failure as well as non-cardiac disorders, for example, renal, hepatic, lymphatic. In the abdomen, significant fluid overload manifests as ascites, as ascites. Marked ascites causes visible abdominal distension, which is tense and non-tender to palpation, with shifting dullness on abdominal percussion and a fluid wave. The liver may be distended and slightly tender with a hepatojugular reflux present. Hepatojugular reflux present. Extremities. In the extremities, primarily the legs, fluid overloads is manifest as edema, which is swelling of soft tissues due to increased interstitial fluid. Edema may be visible or on inspection, but modest amounts of edema is very obese. Edema in very obese or muscular people, maybe athletes, may be difficult to recognize visually. These extremities are palpated for presence and degree of pitting, visible and palpable depressions caused by pressure from the examiner's fingers, which displaces the interstitial fluid. The area of edema is examined for extent, symmetry, for example, comparing both extremities, warmth, erythema, and tenderness. With significant fluid overload, edema may also be present over the sacrum, genitals, or balls. Tenderness, erythema, or both, particularly when an unilateral, suggest an inflammatory cause, for example, cellulitis or thrombophlebitis. Non-pitting edema is more suggestive of lymphatic or vascular obstruction than fluid overload. So I guess that's enough for today. Bye, see you. Oh, okay, don't forget to follow visual guide, huh? I will prepare that. Bye.